Hello, you are most welcome, ladies and gentlemen, to Real Impartation Moment on Tuesday Night Anatomy with Daniel Okwan. Today's section, I want to quickly run with you the inguinal hernias. Yes, of course, I'll add femoral hernias to it. I'll get to know that if you talk about hernia, then we are talking about an organ, protruding through a weak wall. Yes, because the wall is weak, then the organ that is supposed to be contained within the wall, yes, may herniate through, go through the wall. Okay, now if the hernia is occurring in the groin region, then we are going to call it inguinal hernia. Yes, of course, you know that inguinal hernias, they are the commonest type of hernia that we have. Okay, but of course, we also add femoral hernia because, yes, in the medial aspect of the upper thigh, yes, we are going to have that one being the commonest type in females. And so, without much ado, let's set the ball rolling looking at these hernia types we have. So there we are. Now, those of you who have not watched my video, yes, you realize that with the help of what we call the Hazelbeck's triangle, yes, Hazelbeck's triangle, that is where we have what we call direct inguinal hernias occurring. Okay, and that one will occur, medial to this kind of inferior epigastric vessels. And then occurring lateral to this, inferior epigastric vessels, we have what we call indirect inguinal hernias. Okay, so that is what we see. And one thing that we know is that these hernia types occur above this, inguinal ligament, above the inguinal ligament. Yes, we look at how these, hernia types occur. But the other type of hernia, which of course we said the commonest type we have in what we call in females, is what we call femoral hernia. And one thing that we know about femoral hernia is that it's occurring below this inguinal ligament. I'll show you other details of it. But one other thing too that we know is that it's this femoral hernia, okay, will occur medial to this kind of femoral vein. Now remember that, in what we call the femoral triangle, we are going to have three main structures being there. We're going to have the femoral nerve being the lateral most, which is not enclosed in the femoral sheath. Yes, enclosed in, yes, roughly its upper 4 centimeters portion will be the femoral vessels. Okay, femoral artery being lateral, and then femoral vein medial. And so the one which is just medial, which is just lateral to what we call the femoral canal. Remember that femoral canal is a subset of femoral sheath. Okay, and this femoral canal, yes, that is where this kind of femoral hernias can occur, and that one will occur therefore lateral. Okay, just lateral, medial to what we call femoral vein, and not femoral artery, because femoral artery is even lateral to femoral vein. Okay, so that is what I want to show you. These are the three things we want to look at. And so I want to begin with how indirect inguinal hernias occur. Now remember that indirect, we talk about hernias, and we say that the commonest type of hernia we have is what we call inguinal hernia. Those hernias occur in the groin region. But precisely the commonest hernia type we have, okay, as far as humans are concerned, whether male or female, is what we call indirect inguinal hernias. And we want to see what this indirect inguinal hernias. But before I tell you what this indirect inguinal hernias, okay, then let me just show you how the testes descends. Although I've done this video, you can watch the male reproductive system that I've done. I've shown how this kind of testes descends eventually from the abdominal wall, or eventually getting into the scrotal sac. Okay, so what we find is that with the help of some hormones, okay, some hormones will influence the descent of the testes, such that from the posterior abdominal wall, yes, this testis will descend all the way into what we call the groin region, that's the inguinal region. And then from there, usually it's around the 12th week of intrauterine life. From there, it will get into what we call it will migrate into what we call the inguinal canal. Okay, around 28 weeks of intrauterine life, and then eventually with the help of this fibrous band we have over here, which we call it gubernaculum. Okay, gubernaculum testis, yes, it's in the female. Yes, we also have some in the female, also helping to bring all the way the ovary into what we call the pelvic region. Yes, so that the pelvic will reside in what we call the ovarian, bringing the ovaries into the pelvic region. so that the ovaries will reside in what we call the ovarian foci. Yes, with the help of this same gubernaculum in males, we are pulling it all the way into what we call the scrotal sac, because that's the final destination, and that one will take place by the 33rd week of intrauterine life. So as I said, from the anterior abdominal wall, yes, all the way into the inguinal region, yes, usually around 12 weeks of intrauterine life. Then around 28 weeks of intrauterine life, it gets into the femoral canal. Eventually, get by 33rd week of intrauterine life into what we call the scrotal sac with the help of some hormones, yes, and of course under the influence of the pull of this gubernaculum testis. Okay, so that is what we find. Yes, we know the various anomalies which can occur with this, where we talk about undescended testis, yes, or the concealed testis, or cryptorchidism. Yes, those kind of things can occur. Okay, we talk about these ones, especially in preterm babies, tend to experience this kind of, undescended testis. Okay, of course, we also talk about ectopic testis, which of course it doesn't go through the inguinal canal. You may find a different way, it can even go to a thigh, the anterior abdominal wall, different pathway altogether. Those ones are ectopic, find yourself in the wrong place. But at the same time, as this testis is pulled with the help of this gubernaculum, yes, what we also find is that the peritoneum, okay, of the abdomen, what happens is that also forms an invagination. So as you can see over here, it also forms an invagination, okay, on each side of the midline, because we are going to have two testes, yes, on each side of the midline into what we call the abdominal wall. And that invagination which we are seeing over here is known as processus vaginalis. Processus vaginalis. It therefore tells you that this processus vaginalis, yes, is moving alongside as the gubernaculum is coming down, it's also coming down. Okay, and that is why we say that this processus vaginalis, alongside the muscles and other fasciae around over here, yes, will contribute to the wall of this, this inguinal canal that we are talking about. Okay, so it will contribute to it. But one thing that we find is that after the descent of the testis into the scrotal sac, then this processus vaginalis, which we find over here, this opening will have to close. And that is why patency, okay, of this processus vaginalis can create the pathway for what we call, indirect inguinal hernias. The word is indirect inguinal hernias. And because you can see that it's in close relation, yes, it's also entered the scrotal sac, then it means that in indirect inguinal hernias, yes, the herniation, okay, of what we call, for instance, if it's the bowel, okay, it can enter what we call the scrotal sac. It can enter the scrotal sac. That is what I want you to know. So that is how this whole, what do you call it? Indirect inguinal hernias, okay, being the commonest type of hernia in both males and females. So there we are now. So as I was talking about indirect inguinal hernias, okay, now one thing that you have to know is that this important vessel that I talked about, okay, we said that these hernia types are occurring above what we call the inguinal ligament. But of course, with this blood vessel, this blood vessel that we have over here, okay, there's inferior epigastric vessels, yes, inferior epigastric artery and vein, inferior epigastric vessels. These inferior epigastric vessels, what we find is that if it is indirect inguinal hernia, because it's occurring, outside the Hazelbeck's triangle, then it's going to occur lateral to what we call, this inferior epigastric vessel. Now, in case now you can see the same vessel over here. This time around, this hernia type is occurring medial, okay, to this, inferior epigastric vessel. So let the inferior epigastric vessel be your landmark. So whenever there's a clinical case study, yes, they can give you a whole lot of information. But what you are looking for is that that type of hernia occurring above the inguinal ligament, then it's likely, what inguinal ligament, then it's not femoral, but rather inguinal hernia. Then you have to discriminate whether it's direct or indirect, okay? And what we say is that whether it's occurring, medial, okay? If it's occurring medial to what we call this inferior epigastric vessel, then it is direct. But the one where it's occurring lateral to what we call inferior epigastric vessels will be the indirect inguinal hernia type. And we said that one is due to non-closure or patency or weakness in what we call, the processus vaginalis, okay? So that's what we see. And that is why we say that, indirect inguinal hernias, yes, is usually congenital, more than in the case of an injury or old age. It's more congenital, okay? And we said that, yes, it's going to occur. Yes, we find it in both, although males and females. What is happening is that we find it more in males than, of course, in females. Okay, yes, then again, as we said, yes, it can get into the scrotal sac. Then in case of females, it can get into what we call the labia majora, because of course we know that the scrotum, in case of females, that's the, homolog, okay, homologous structures. Yes, that's the labia majora. And as I indicated, it's going to occur lateral to what we call the inferior epigastric vessels. Okay, lateral to inferior epigastric vessels. Yes, of course, because it is going through, this processive vaginalis is contributing to the wall of what we call the inguinal canal. Then it makes sense that this hernia, okay, will be seen running through what we call the, inguinal canal. Of course, starting from what we call the deep inguinal ring. Okay, so that is what we are going to see. But in the case of femoral hernia, for instance, you see that the inguinal canal will be empty. There will be nothing over there. Yes, of course, in case of usual the direct, you not really see it in the inguinal canal. Okay, rarely will you see it there. So of course it will take the same course as that of the spermatic cord. Yes, that's what we are saying. So traverse what we call the inguinal canal. That is what we call indirect inguinal hernia. Now, in the case of direct, it's exactly opposite to that one. Yes, usually it will occur in old age. It's non-congenital. Yes, so usually it will occur in old age because, of course, you have used the abdominal wall so much. Yes, there's some kind of weakness, okay? And so that one rarely will enter the scrotal sac. It will enter. Why? Because the process vaginalis is closed already. So it won't enter. It won't give you that pathway to enter. But one thing I've already told you is that it's going to occur medial. Okay, it's happening medial to what we call this inferior epigastric vessels. Okay, that is what we see. And directly it will occur behind what we call the superficial inguinal ring. So it's not going through the inguinal canal anyway. Yeah, so that is what we see. And the main thing is that there's a bulge through what we call the weakened, fascia of what we call the abdominal wall. Yes, that is what we see. And that is why if you want to look at what we call the layers, okay, from inside out, then what will happen is that the layers, what will be the things which will be layers of the abdominal wall, which will be surrounding this kind of hernia. And that one, usually, what we are going to see is that you see what we call the extraperitoneal fat layer. Then below that, we're going to see what we call the transversalis fascia being the endo-abdominal fascia. Yes, of course, even the conjoint tendon will be there. Okay, we said it's occurring what we call medial to what we call inferior epigastric vessels. So yes, conjoint tendon will also be there. Then of course we also have what we call external spermatic fascia also surrounding it. So as you come down, and then eventually we get to what we call the skin. So yes, sometimes in your exam they may want to tell yes these kind of layers that you find, okay, covering what we call this kind of direct inguinal hernia. Okay, so as I said, extraperitoneal from inside out, extraperitoneal fat layer. Then, of course, we go to what we call the endo-abdominal fascia, being the transversalis fascia, even the conjoint tendon. Yes, we talk about external spermatic fascia and then even skin, contributing to what we call the layers that form what we call the direct inguinal hernias. So these are the things that we are looking at. So there we are, as we indicated. Yes, this is the area, this is the Hesselbeck's triangle. And of course, we have what we call inferior epigastric vessels over here. Okay, and then even lateral to inferior epigastric vessels, those where indirect inguinal hernias okay. So if you are asked where does direct inguinal hernias okay, then it okay in what we call the inguinal triangle, or something we call the Hesselbeck's triangle. Okay, that is over here, and that one is medial, okay, to inferior epigastric vessels. Then indirect inguinal hernias, which will go through this inguinal canal, yes, will occur lateral to inferior epigastric vessels. Then one thing that we know is that the inguinal ligament is over here. These kind of hernias will occur above the inguinal ligament. Then occurring below inguinal ligament in what we call the femoral canal, yes, we have what we call the femoral hernia. Now remember that femoral hernia, okay, is the commonest hernia type you have in females. If you ask this question, that's your answer. And also, as I said, yes, we have femoral artery, we have femoral vein. Okay, the one which is the blood vessel which is very close to it, laterally, is what we call the femoral vein, and not femoral artery, because femoral artery is even lateral to femoral vein. Okay, and even femoral nerve is lateral to what we call femoral artery. Okay, so that is what we find over here. Okay, now one thing is that if you want to really compare femoral hernias with that of inguinal hernias, then one thing that you have to know is that in femoral hernias, yes, reducibility is more likely compared to that of, inguinal hernias. Less reducibility in case of inguinal hernias. Okay, that is, one thing that I want you to know. And of course, yes, in femoral hernias, they are not occurring, relative to what we call the inguinal canal. So it means that inguinal canal will be empty. Okay, just like you find it mainly in for direct inguinal hernia. So inguinal canal will also be empty. Okay, so that is, that one that I want to know. Now, one thing that we have to know is that whatever hernia type we have, okay, then one thing that you have to know is that, yes, it could be an incarcerated hernia. Yes, if your care is not taken, it becomes incarcerated. It gets, obstructed, so to speak, over here. So it becomes highly irreducible, okay? And because of that, it's painful. Although the blood supply is there, yes, it becomes very painful. So when there's that kind of obstruction, okay, for instance, these bowels getting obstructed over here, going through the abdominal wall, okay, then what will happen is that although there's good blood supply, yes, it is painful and it's very irreducible. But when this same thing happens, it goes on and it gets strangulated. Now, in case of strangulated hernias, then what will happen is that the blood supply becomes compromised, because the blood will not be getting to this area. So can you see the color change over here? Yes, that is what is going to happen, leading to systemic toxicity and all that. Yes, the pain continues even after reduction. Okay, although we know in general it's irreducible. And of course, the main signal cardinal sign over here is that there will be ischemia. Okay, so in the case of strangulated hernia, we have ischemia. But in the case of incarcerated, there's no ischemia, although both of them, yes, because of course in incarcerated hernia, there's good blood supply, unlike in the case of strangulated, hernia. All right, I hope you find this meeting helpful. I'm very grateful for your time this evening. I dedicate this video to my father, Mr. Daniel Kofi Abam Okwan, yes, for his love and care, for everything that he's done for me and continues to do. I'm very grateful to all fathers. Yes, I wish you all happy Father's Day as well. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.